3:30.
And thank you, Kelly. I appreciate that. Hello, everyone, and welcome to the statewide substance use response working group subcommittee number 2 treatment and recovery meeting today. As noted, today is we're starting on time, which I'm happy to see. And right now, I'm going to call to order this meeting, and we'll have Kelly from SEI to call the roll, please.
Thank you, Madam Chair. For the record, Kelly Marshall with Social Entrepreneurs. Please indicate your attendance by saying aye or present. Assemblywoman Claire Thomas.
Present.
Chelsea Cheatham. Dr. Leslie Dixon.
Present.
Jeffrey Iverson.
You need to take yourself off mute.
I am present.
Lisa Lee.
Present.
Steve Shell. Madam Chair, we have 4 of our 6 members and we have a quorum.
Great. And just make a note that if any other members come in, we can call them as present also.
Thank you, Madam Chair.
Okay. Agenda number 2 is our public comment. So public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020.
Thank you, Madam Chair. And just for the record, Chelsea Cheatham is now present. So another one of our subcommittee members has joined. And I'm noting that Marcy Ryba has raised her hand for public comment.
Thank you.
Good afternoon. My name is Marcy Ryba, and I serve as the Executive Director for the Department of Indigent Defense Services in Nevada. The Department of Indigent Defense Services is tasked with oversight and support of indigent defense providers throughout Nevada. Historically, little attention has been paid to indigent defense in the ongoing conversation of criminal justice reform. However, indigent defense providers are an essential piece of this plan for Nevada to effectively combat this opioid epidemic. Public defenders can turn the wave of addiction because they are uniquely situated to provide aid at intercept level 2 on the sequential intercept model, which was developed by the Gaines Center. Public defenders are often the first person to have an impact on an individual's opioid addiction after arrest. We're hoping the subcommittee will consider funding a holistic resource center, or an HRC, and support the evidence-based practice of holistic defense for indigent defense providers. This is especially needed in the rural counties. The HRC would make connections with treatment providers and indigent defense providers across Nevada. And when you think about it, Nevada provides social workers to courts. But if you open up to the court, you face possibly contempt if you admit to use. They provide social workers for the prosecution and law enforcement. But if you admit to them that you're using, then you also face punishment for that admission. If Nevada starts to provide social workers for public defenders, that admission of use is protected by that attorney-client privilege, and that attorney can get that person into treatment. Who will these individuals be most open and honest with? And likely, I would say it would be the public defenders and their social workers, and we could really attack this opioid epidemic. Our model, or the holistic defense model, is based on the idea that to be an effective advocate, public defenders must adopt a broader understanding of the scope of their work. They must not only address the immediate case at hand, but also the collateral legal consequences of criminal justice involvement like loss of employment, public housing, custody of children, and immigration status. Underlying life circumstances and non-legal issues often play a role in driving our clients into the criminal justice system, and this includes substance abuse addiction, like opioids, mental illness, family and housing instability. A RAND Corporation study on holistic defense found key findings that over a 10-year study, holistic representation prevented more than 1 million days of incarceration. It reduced the likelihood of a prison sentence by 16%, and actually the prison length by 24%. It saved taxpayers an estimated $160 million in inmate housing costs alone. And holistic defense can significantly reduce incarceration and save taxpayer dollar without harming public safety. Our department is willing to assist in any way, and we hope that this subcommittee sees us as a partner in this process to address the opioid crisis. Thank you.
And thank you, Ms. Ryback. And Kelly, anyone else?
I do not see any other hands raised. And if there's anyone on the phone who would like to make public comment, please unmute yourself and proceed. I don't hear or see anyone, Madam Chair.
All right, thank you, Kelly. And our next agenda item, but before we go on, I just want to make note here. When we're in this subcommittee, that the statewide substance use response working group, SURG, may 1, take agenda items out of order, 2, combine 2 or more items for consideration, or 3, remove an item from the agenda or delay discussion related to an item at any time. If you have a disability and require a reasonable accommodation to fully participate in this event, please contact Vicki Beavers, Executive Assistant to Attorney General at 702-684-1212 or bbeavers@ag.nv.gov in advance to discuss your accessibility needs. Okay, so the next agenda item is number 3, our member introduction. So I will go first, and well, actually, Kelly, why don't you introduce the members and we'll take it from there.
Thank you, Assemblywoman Thomas. Okay, so Chelsea, what we're hoping is that you can share the role that you play on the SURG, which is listed on the screen, and then any areas of expertise or particular interest for you that would be important for this subcommittee to know.
Sure. Hello, everyone. My name is Chelsea Cheatham. I am the program manager at Track the Exchange, which is the syringe service program located in Southern Nevada. We're located in Las Vegas. I am the harm reduction program person on the SURG subcommittee, on the SURG committee, and I am interested in all things harm reduction related. I also currently serve as the deputy director of the PACT Coalition, so I also work in primary prevention as well. And I'm definitely very interested in harm reduction, syringe service, and just that sort of thing. But thank you.
All right. Thank you, Chelsea. Dr. Dixon.
Okay, yes, I'm a physician, I'm a psychiatrist, and boarded in addiction psychiatry because I've been doing addiction psychiatry since 1990, when I went to work full-time for the VA in Lexington, Kentucky, and worked on the inpatient unit. And if you know very much about veterans and mental health, a lot of them have substance use disorders. So I then eventually became boarded in addiction psychiatry when we were able to, what we call grandfather into the into the boards. And so what I do is I'm retired from the VA a few years ago. So now I work as one of the medical directors for, which used to be Center for Behavioral Health, now is Behavioral Health Group Recovery. It was a merger. And so I take care of individuals who mostly have opioid use disorder, some alcohol use disorder, and nowadays a lot of amphetamine use disorder. That's what I do that's relevant to this committee. I do a lot of other things too.
Thank you, Dr. Dixon. Mr. Iverson?
Hello, everybody. My name is Jeff Iverson. I'm a person in long-term recovery. I've been abstinent since March 28th of 2006. I also serve as the founder and CEO of a nonprofit organization named the Freedom House in Las Vegas. We have a 40-bed inpatient treatment center and a 100-bed transitional center for primarily individuals in the criminal justice system who need inpatient, outpatient, or housing and other services. I'm also the founder and managing partner and CEO right now of Crossroads of Southern Nevada, located by UMC in Las Vegas. We are a inpatient and medical detox facility with also 120 beds of transitional housing for our members. We're an approved drop-off site for Metro and first responders, for people that might be in crisis or need substance use treatment services. And I also do a lot of other things, but I'm really, really happy to be participating on this committee. Over the years, I feel like because of my own experiences, I relate well with individuals who are struggling, and I've tried to use my experiences as the best I can when I'm working to develop programs to help people. So thank you.
Thank you, Mr. Iverson. Ms. Lee?
Good afternoon, everyone. Lisa Lee here. I am a program specialist with Washoe County Human Services Agency in the CQI and training unit. I am also a person in long-term recovery. I have played a lot of roles out in the community, from case manager to outreach worker to certified peer recovery support specialist. I'm also a peer supervisor. I've been a drug and alcohol counselor. I'm currently a doctoral student in public health. My dissertation looks at the ways in which parental substance use intersects with the child welfare system. And I have been involved in harm reduction on one end or another since the mid-1990s. So that's really where my passion is, not just from a risk reduction standpoint, but also kind of a broader ethos in standing with marginalized populations and empowering those communities. Oh, and I left out another piece. I have also engaged in a lot of research with people who use drugs statewide. Thank you.
Thank you, Ms. Lee. Madam Chair, that concludes our member introduction of the members who are present. I just also wanted to note that we do have representation from the Attorney General's office. So if at any point you have a question for the DAG, we do have Rosalie available for us.
Thank you, Kelly. I appreciate that. And Kelly, you know, we're going to put you into some double duty here. Right now, I'm going to hand it back over to you because I think it's important for us to know the committee scope and the roles of the committee members and the roles that we will play during this subcommittee for the treatment and recovery. So if you will, we can go to the committee scope.
Thank you, Madam Chair. And I should be sharing that now. Hopefully everyone can see that. Can you all see the committee scope slide? Thank you. Okay, so you know that you are one of 3 subcommittees. This is the Treatment and Recovery Subcommittee, and we have parsed out sections of the legislation. So this committee's scope is encompassing of special populations. We have asked other work groups to also consider them, but this subcommittee is specifically charged with looking at special populations, specifically around Area C, which you'll see on the next slide. And those subpopulations include veterans, elderly persons and youth, persons who are incarcerated, persons who have committed nonviolent crimes, primarily driven by a substance use disorder, and other persons involved in the criminal justice or the juvenile justice systems. They also include pregnant women and the parents of dependent children, lesbian, gay, bisexual, transgender, and questioning persons, persons who inject drugs, which is a revision. Thank you, Ms. Lee, for that. Children who are involved with the child welfare system, and then other populations who are disproportionately impacted by substance use disorders. So this committee's scope, we are tasked with making progress to leverage and expand efforts by state and local governmental entities to reduce the use of substances which are associated with substance use disorders, including, but without limitation, heroin, other synthetic and non-synthetic opioids and stimulants, and to identify ways to enhance those efforts through coordination and collaboration. So that is letter A. We are also charged, or you are also charged with making progress on making recommendations to entities, including without limitation, the State Board of Pharmacy, professional licensing boards that license practitioners other than veterinarians, the State Board of Health, the division, the governor, and the legislature to ensure that controlled substances are appropriately prescribed in accordance with the provisions of NRS 639.2391 to 639.23916 inclusive. And then category J in the legislation is tasking this work group with making progress to study the efficacy and expand the implementation of programs to educate youth and families about the efforts of substance use and substance use disorders. You also have shared responsibility to assess category B, which is evidence-based strategies for preventing substance use and intervening to stop substance use, including without limitation the use of heroin, other synthetic and non-synthetic opioids and stimulants. And those strategies must include without limitation, helping persons at risk of a substance use disorder avoid developing a substance use disorder, discover potential of problematic substance use in a person and intervene before the person develops a substance use disorder, treat the medical consequences of a substance use disorder in a person, and facilitate the treatment of the substance use disorder to minimize further harm, and 4, reduce the harm caused by substance use, including without limitation by preventing overdoses. You also share responsibility with the other work groups to assess and evaluate existing pathways to treatment and recovery for persons with substance use disorders, including without limitation such persons who are members of special populations. And this is actually a core function of this work group. You have shared responsibility to examine qualitative and quantitative data to understand the risk factors that contribute to substance use and the rates of substance use and substance use disorders, focusing on special populations. And finally, to study, evaluate, and make recommendations to the Department of Health and Human Services concerning the use of the money described in Section 10.5 of this Act to address substance use disorders. That concludes the scope of the committee, Madam Chair.
Thank you, Kelly. And as the next slide, you can see what our roles are. And, we have to attend our meetings and communicate to the chair when unable to do so, provide recommendations in advance of each meeting, and to review materials provided in advance of each meeting. So I'd appreciate that. And some of the roles for the committee members, the SURG committee, subcommittee are expected to meet monthly and will have a chair, which I will chair, and targeted administrative support. Groups will engage subject matter experts from Nevada and beyond to inform their study and recommendation. The term for the subcommittee membership is expected to be 1 year, beginning in March of 2022 and extending to February 2023. Other important milestones are listed below. March, in which we know DHHS needs assessment update, announce subcommittee members and chairs, presentations, that was completed. June, subcommittee progress reports and presentations based on monthly meetings. And September, with subcommittee recommendations, report, and discussions. January will be our final report presentation and approval. So right now, our next agenda item is agenda item number 4, review subcommittee recommendations tracking tool. And I want the committee to note that we are transitioning to a survey rather than sharing the individual Excel spreadsheets for the future meetings to give subcommittee members a simplified way to make recommendations while adhering to the open meeting law. So if I can have Kelly walk us through the examples that her and the team have worked on, which I believe will make life so much easier for us. So Kelly.
Thank you, Madam Chair. Kelly Marshall for the record. So I wanted to note, we are the 3rd subcommittee meeting. So 2 meetings have already occurred, and we've gleaned some wisdom from those other 2 meetings. So one of them is, as Madam Chair described, we have provided a survey, and at least one member of our subcommittee has used that survey to forward recommendations to us. But you also received a spreadsheet, and so we are agnostic about which you use to provide feedback to us. This is what the spreadsheet looks like. We populate the spreadsheet with the survey results if you choose to use the survey link. However, if you would prefer to use the Excel spreadsheet that we issued previously, you are welcome to do that, and you can fill it out simply by putting your name under the sponsoring member column. You list your recommendation, and then there's a drop-down menu under column C to identify what section of the requirements your recommendation is speaking to. We understand that there may be some confusion about the cross-cutting elements. Those elements are found on the spreadsheet. They're also listed on the survey. However, if you're not certain where they fit, you can skip that column. It's not a required column. What is of interest is if you can cut and paste or list on the survey, you can actually check boxes. Any special populations that you feel that recommendation is specifically geared towards, and those are listed for you. That's what we just reviewed in the scope. And then if you have a justification, so for example, in the case of the example we have, it was a recommendation from Dr. Woodard that was presented at the February Interim Health Committee, and it was around expanding access to medication-assisted treatment. And so this treatment approach has been shown to improve patient survival, increase retention in treatment, decrease illicit opiate use and other criminal activity among people with substance use disorders, increase patients' ability to gain and maintain employment, improve birth outcomes among women who have substance use disorders and are pregnant. So those justifications are helpful for other subcommittee members when you have them. However, if you are not able to list that piece out, you can make the recommendation without the justification. And then if you happen to have some research links or some supporting documentation that you would like to provide, there's an opportunity to provide links as well. If there's a specific action step you would like to request, so Ms. Lee has forwarded one and she made a specific recommendation on, I believe, both of her, or she made a specific action step on both of her recommendations, you can do that. And then as this work group continues to convene, you can collectively build out whether it's short or long term, and if a fiscal note is needed. However, if you have advisement for the rest of your work group members, you are welcome to place that as well. So we're hoping that people just feel comfortable either using the survey link and submitting individual recommendations that way. You can use it as many times as you would like, or using the spreadsheet. And this document will be posted to the AG's website so that you will see all of the recommendations listed, which include all of the interim health committee recommendations from February and from March. Madam Chair, I see that Ms. Lee has her hand raised.
And Ms. Lee, please.
Thank you, Madam Chair. I just have a quick question. Is there a deadline? I still have a few more recommendations to make. Is there a deadline for when we must get those in?
Madam Chair, if I may.
Yes.
Kelly Marshall for the record. There is no deadline. It is really a rolling deadline. I think what we're managing towards, Ms. Lee, is that when you meet in May, that you would have a comprehensive list that you could start to sort through so that you can forward recommendations to the larger SURG subcommittee with some sense of prioritization as opposed to the kitchen sink.
Thank you.
Any additional questions? Does this, I just want to make sure that, the Excel and or the survey is working for everyone that's on the subcommittee. Is that okay? All right. Okay. Sounds good. Well, we'll move on to agenda item number 5, which is the baseline information for treatment and recovery. And we have Dr. Woodard, who will be presenting. Dr. Woodard.
Hello, good afternoon, Madam Chair and committee. Kelly, if it's okay with you, I will share my screen.
So I've stopped sharing. You should be able to go ahead and share.
Okay. And can you see my screen? I'll put it in. Is it in presentation mode? I see thumbs up. Okay, wonderful. Yes, okay, wonderful. So good afternoon, everyone. My name is Stephanie Woodard. I am the Department of Health and Human Services Senior Advisor on Behavioral Health. You may recall in a previous SURG meeting, the request was that we at the state provide a brief overview of some information and infrastructure as it relates to the way that substance use disorder prevention, treatment, harm reduction, and recovery support services are designed in the state. So I just want to pause before I start my presentation and say that the beauty of having these subcommittees is that we have subject matter expertise that is incredibly deep. And so by no way is this presentation meant to be exhaustive, but we also recognize that there may be individuals on each of the subcommittees that are not as familiar with the service delivery systems within the state. And so the goal of these presentations is really just to provide some foundational information to be used by committee members, especially recognizing that at times we do have members that will be joining us with lived experience, but may not necessarily have the background that many of you are already coming with because of your positions or roles within the state. So I will move on. The goal for this presentation is to provide a brief overview of substance use treatment and recovery programs. So to begin, I think it's important to recognize that within DHHS, we have two primary payers as it relates to substance use disorder treatment and recovery. We have the Division of Public and Behavioral Health, and we have the Division of Healthcare Finance and Policy, also known as our state Nevada Medicaid office. Within the Division of Public and Behavioral Health, the funds that we use to fund substance use disorder treatment and recovery include grant funding, and this may be federal grant funding, but it also may be endowments, foundation dollars, or private grants that the state receives, as well as state general fund. We actually have an allocation of state general fund that we use for what is called maintenance of effort. So in order for the state to receive our substance abuse treatment and prevention block grant, we must evidence to the federal government and to SAMHSA that the state remains committed in investing our own dollars in prevention and treatment services. So that is where some of the general fund comes from. Those are legislatively appropriated dollars that the state can hold up to demonstrate that we are maintaining our fiscal efforts for substance use disorder treatment and recovery services. On the other side of the house, within the Division of Healthcare Finance and Policy, that agency uses state general fund so that it's able to pull down a federal match. And that federal match varies depending on the eligibility category that the individual who's enrolled in Medicaid fits within. The Division of Public and Behavioral Health actually serves as a regulator as well as a payer. I'll get into this a little bit later, but from the regulatory standpoint, if you are a healthcare facility, oftentimes you are required to be licensed through our Bureau of Healthcare Quality and Compliance. And then you are also supposed to be certified as a substance use disorder provider. So we have a regulatory role, but we also then have a payer role. So we have several substance use disorder treatment programs that are receiving direct grant funds. And some of this is also on a fee-for-service basis. So we are funding services very much like a small healthcare organization to ensure that individuals who are uninsured or underinsured have access to safety net services. Where on the Medicaid side, they really do serve as a primary payer for substance use disorder treatment and recovery services. Division in Public and Behavioral Health, we cover an array of substance use disorder services, including outpatient, residential, and transitional living. Now, this varies pretty considerably currently with the Nevada Medicaid. They're limited currently to only being able to provide services, funding for services on an outpatient and an inpatient service level. They do not fund residential treatment services or transitional living. There are some exceptions to that, and it has to do with some nuances with managed care organization contracts. But for now, I'll set that off to the side because it gets a little confusing. On the Division of Public and Behavioral Health side, we certainly have seen consistent gaps, which include sufficient funding for those higher levels of care, including residential treatment services, withdrawal management services, as well as transitional living. Where on the other side, the gaps in Nevada Medicaid really have to do with the institutions of mental disease, or the IMD federal rulings, which limit the ability for states to receive Medicaid reimbursement for services that are provided in institutions or facilities that are considered institutions of mental disease. This means that we've had a very challenging time in Nevada to be able to provide a vast array of residential and inpatient services for individuals within the Medicaid program. On the Medicaid side, there is no requirement for priority populations. If you meet medical necessity for a service that is covered under Medicaid and you are a Medicaid enrolled recipient, you are able to receive that service. The federal requirements from SAMHSA, however, on the Division of Public and Behavioral Health actually require that we ensure adequate and timely access to individuals in priority populations. And those priority populations include pregnant women, who also use intravenous drugs, pregnant women without intravenous drug use, but because they are pregnant, they are a high priority population. And then the third priority population are individuals who inject drugs. And those three populations together make up the priority populations that are stipulated in federal regulations for the use of our substance abuse treatment and prevention block grant dollars. We also are required by the federal government on the Division of Public and Behavioral Health side to require additional data collection and reporting. This data collection and reporting tool is called the Treatment Episode Data Set, which is also called TEDS data. There are significant limitations in this TEDS data, primarily because it is only currently reported by those treatment providers that are funded through the Division of Public and Behavioral Health. So we really only get a very small snapshot of the admission and discharge data, as well as national outcome measure data from the funded programs within the division. We do not require, like other states do, all substance use disorder treatment providers, including those in Medicaid, to collect and report on similar data sets. We do include recovery support services on the Division of Public and Behavioral Health side, which also includes not only peer recovery supports, but other recovery supports. Whereas on the Medicaid side, currently, their recovery support services are primarily limited to peer recovery support services. So within the Division of Public and Behavioral Health, the majority of the treatment and recovery funding is managed by the Bureau of Behavioral Health, Wellness, and Prevention. Many of you may also be familiar with SAPTA, which is the Substance Abuse Treatment and Prevention Agency. So SAPTA is a program within the Bureau of Behavioral Health, Wellness, and Prevention. The two primary funding streams are the Substance Abuse Mental Health Services Administration Substance Abuse Block Grant, or SABG, and the State Opioid Response Grant. These grants help to not only fund essential safety net services on the substance use disorder treatment and recovery side, but they also are used to stand up programs and services with an eye towards sustainability, typically within the state Medicaid agency. So some nuances here are that the majority of our funds go towards funding residential treatment, transitional housing, case management, supporting the development of recovery-oriented systems of care, and expanding access to recovery support services for adolescents as well as adults. And you'll note to what we are funding is primarily the gaps that are not available within our state Medicaid plan. In addition, we have state general funds that help to support Medicaid and infrastructure within the division to expand prevention and treatment for individuals who are involved in the justice system, reentry, and social services. And Medicaid expanded their array of services to include substance use disorder treatment services back in January of 2014 with the advent of the ACA. So you can imagine we've got two treatment delivery systems that actually work very well in collaboration with one another, but it does require a lot of close collaboration and coordination between the Division of Public and Behavioral Health and Nevada's Medicaid. We have a number of different advisory committees that play different roles within the state to guide the Bureau of Behavioral Health, Wellness, and Prevention on all things as it relates to prevention, treatment, and recovery support services. This includes the Multidisciplinary Prevention Advisory Committee, who really does help to develop the statewide prevention strategy. We have the SAPTA Advisory Board that ensures availability and accessibility of treatment and prevention services within the state. The Regional Behavioral Health Policy Boards, as well as the Regional Children's Behavioral Health Consortia, help to ensure that we are gathering information from all of the regions across the state to be taken into consideration when we are developing our state plans for the allocation of funds from the block grant and state general fund. And then of course, the role of this group, the Substance Use Response Working Group, which will be working to develop the state plan for substance use prevention, harm reduction, treatment, recovery, and response. And that plan will again assist the state as we go forward, apply for grants, and administer the federal funds that we already receive. Nevada has over 160 different SAPTA certified substance use disorder treatment providers statewide. SAPTA certification is actually required to become a Medicaid provider that is enrolled to provide agency level substance use disorder treatment services. SAPTA certification is also required for all funded programs through the Bureau of Behavioral Health, Wellness, and Prevention. In many ways, on the substance use disorder treatment side, our programming is much further evolved than on the mental health side, because we have minimum requirements that all certified providers must meet in order to be able to either enroll in Medicaid or receive federal funding. We also have the Bureau of Healthcare Quality and Compliance, which licenses facilities. And those facilities include hospitals, detox centers, residential and transitional housing facilities, crisis triage centers, and they also work to certify our certified community behavioral health centers. This is important because you may have a health facility that is not only licensed by HCQC, but also then certified through the Bureau of Behavioral Health, Wellness, and Prevention. So really noting that there are a lot of requirements that our treatment providers are required to meet, and a substantial amount of oversight, including assurance that they are meeting some of the best practice standards. This group will have the opportunity to bring subject matter experts to the table to provide presentations and information. And some recommendations for subject matter experts that this group may want to contemplate for future meetings include the Center for Applied Substance Abuse Technologies, or CASAT. CASAT is contracted with the state to provide the certification reviews. Also an opportunity to speak to funded substance use disorder treatment providers, as well as those that are not funded through the Division of Public and Behavioral Health, but are potentially in the community, whether or not they accept Medicaid. And then certainly having the Division of Healthcare Finance and Policy be able to come and speak to this group around some of the coverage and limitations within the state Medicaid plan. So as I mentioned, certification services, we contract with the Center for Applied Substance Abuse Technologies at UNR to conduct our certification site visits for prevention coalitions, as well as substance use disorder treatment and recovery programs. We have been working very closely to ensure that we are instilling requirements that are consistent with the American Association of Addiction, or American Society of Addiction Medicine, sorry, there's a typo there, so that all of the levels of care are actually very carefully aligned to meet ASAM criteria. And then we also provide endorsements using the dual diagnosis capability toolkits, which allow us to evaluate how capable a program is for meeting the needs of individuals with co-occurring mental health conditions. Long ago, we had mainly our substance use disorder treatment providers providing substance use disorder treatment only, mental health providers providing mental health treatment only, and oftentimes you would have an individual that was seeing a substance use disorder treatment professional for their addiction issues and a mental health professional for their mental health issues. Long gone are those days of bifurcating care, and we recognize the inherent value of making sure that that care can be provided in agency and sometimes with the same provider. So really see a need to continue to bolster the capabilities of our programs to provide that co-occurring disorder treatment. SAPTA also certifies our opioid treatment programs, also known as methadone clinics, civil protective custody programs, and there is some NRS that actually allow law enforcement to take into civil custody an individual who is intoxicated to ensure that they are able to receive medical treatment. Drug court services, transitional housing programs, assertive community treatment teams, and we have developed certification for, but we have not yet implemented, certification for supported housing and tenancy supports, crisis residential treatment services, as well as recovery housing. So those are all in the queue, which we are looking forward to being able to launch in the next year to 18 months. If anyone is looking for a treatment disorder, substance use disorder treatment provider in their area, we have also established a website called Behavioral Health NV. This website allows you to search by location, as well as service categories. So you can look to see, based on the level of care, whether you are an adult or an adolescent, if you have treatment available in your area. We also use our certification data to support endorsing providers based on not only whether or not they've met certification, but if there are any issues or concerns with that certification. So this tool is also used to help to communicate how well these providers have actually met certification standards. A little bit more about the treatment and recovery infrastructure. So we have integrated opioid treatment and recovery centers, also called IOTRCs. These were created as the foundation for our medication-assisted treatment hub and spoke model in Nevada. They have moved beyond what we would consider traditional methadone clinic or opioid treatment program services to include things like harm reduction, psychiatry, and access to behavioral health services, case management, and a full array of peer recovery supports as well, recognizing that we needed to build out their capacity if they were going to be the primary providers to provide stabilization for individuals with an opioid use disorder in the community. We have been in Nevada very fortunate to receive a Support Act planning grant as well as the implementation grant. These grants have allowed Nevada to prioritize the expansion of substance use disorder treatment in Nevada. There's been extensive work, and would be happy to point you to some of the documents that have been generated out of this work. A very thorough review of the substance use disorder treatment system within Nevada with an eye towards Nevada Medicaid, looking to see how we can expand access to substance use disorder treatment statewide. It's also allowed us to develop the 1115 demonstration waiver. This demonstration waiver will allow Nevada to be able to actually receive federal reimbursement for services that include community-based withdrawal management services as well as residential treatment. So you will recall it's actually one of the limitations currently within our state Medicaid plan. They're not able to receive federal reimbursement for residential treatment services. So this would actually allow us to open up additional beds and greater access for residential treatment once the 1115 demonstration waiver is approved through CMS, but that waiver is written and is currently in review with CMS at the federal level. As I mentioned, focusing on establishing Nevada's hub and spoke system, including the IOTRCs, but also supporting the development of office-based opioid treatment providers, which also included the development of an alternative payment methodology that recognizes that substance use disorder treatment, specifically for opioid use disorder, for those who are prescribing buprenorphine, looks very different in the induction and stabilization stage than it does in the maintenance phase. And so this has been identified as one way to potentially incentivize providers to join into the Medicaid services and provide medication-assisted treatment in the community. Through our state opioid response grant, we have also focused on expanding access to medication-assisted treatment, also supporting outpatient treatment and recovery services. Through the state opioid response grant, there has now been a recognition from the federal government that stimulants and stimulant use disorder often are co-occurring with an opioid use disorder, and in some cases is actually the primary issue that needs to be addressed in treatment. And so now we are able to actually expand the utilization of these funds to not only address opioid use disorder, but stimulant use disorder as well. And we're actually seeing quite a bit of success with being able to expand these dollars out so that they're not so limited as they have been in the past. Some priorities include tribal treatment and recovery, working with the criminal justice system to ensure individuals who need treatment and recovery services are provided those, expanding access to peer recovery support services, community preparedness planning for our tribal communities, including access to mobile recovery outreach teams, and a primary focus for some of our programs on reducing the impact of neonatal abstinence syndrome or preventing it altogether. There's also been a big push to distribute naloxone kits, including overdose education, a focus on criminal justice deflection and diversion services, recognizing that individuals may have a treatment need that would be better served by being diverted or deflected into treatment as opposed to incarceration and involvement with the criminal justice system. Specialty services for individuals who are unhoused, as well as individuals who are pregnant and parenting, with a lens on diversity and health equity, recognizing that different communities have been disproportionately impacted by substance use. Providing wraparound treatment and recovery support services for special populations. And some of this work includes working with faith-based organizations and helping other organizations really adopt peer-based services. And then an expansion of criminal justice programs to support the utilization of medication-assisted treatment. And more what we are seeing is that it's not just the utilization of medication-assisted treatment during incarceration to support withdrawal management, but also the need to continue that medication as a maintenance medication and to assist people in getting linkage and referral to community-based services upon reentry. Certified community behavioral health clinics are an essential component of the state's infrastructure for substance use disorder treatment. They include 24/7 crisis intervention, ambulatory withdrawal management, and an array of services that occur in the community. We started with 3 CCBHCs. We now have 9 in the Medicaid program, and we have an additional 7 that are SAMHSA federal funded that are working in the communities to establish services. The CCBHCs are safety net providers, so they are required to serve individuals regardless of their ability to pay, and they provide services to adults, children, adolescents, as well as families. We've also been working to establish Nevada's crisis response system. This includes a 24/7 crisis call line and crisis care hub that has transparency into the behavioral health system to ensure that there is a goodness of fit between timely referrals and connection to care for individuals who are in crisis. This can also include a deployment of mobile crisis teams in the community. Similar to when you call 911, you may get law enforcement, EMS, or fire. When you call the crisis call center, which will soon be a 3-digit 988 number, they too would be able to deploy services to the individual in the community where they are at, and those would be our mobile crisis teams. We're also establishing crisis residential services. And these services, again, are allowed through managed Medicaid in Nevada, but we see the need to really expand these services out through the 1115 demonstration waiver, making them available to all Nevadans who need that level of service. And then crisis stabilization centers. So offering a different front door from emergency rooms to crisis stabilization centers for individuals who have immediate behavioral health care needs, but do not need to go to the emergency room for a medical issue. So the other way that we conceptualize crisis stabilization centers are psychiatric emergency rooms. So they're required to bring in everyone when they're dropped off by law enforcement or EMS, or they walk in themselves, or they're referred by others. They're open 24 hours a day, 7 days a week. And provide services in what we consider a living room model. So a warm and welcoming environment that looks very different than an emergency room. And then supporting the development of in-home crisis stabilization services, recognizing that sometimes keeping the individual at home with family, friends, or caregivers close by to be able to support in-home stabilization is a better option than having individuals receive treatment on an inpatient basis. These services distinguish differences between the adult system and the system that serves children, youth, and families. They are required to be responsive to both mental health and substance use related crises, including ensuring that we have capacity and referral for withdrawal management and medication assisted treatment. And they are strongly rooted in recovery and are required across the entire response system to include peer recovery supports. We've also been supporting the development of recovery-oriented systems of care. This recognizes that recovery needs to be supported across the many pathways that people take toward recovery. Sometimes this means that it includes formal treatment services, but for some people, it does not require formal treatment services. And so we need to ensure that our recovery service array is able to meet people where they are at and really allow them to be self-directed and honor their autonomy in choosing the recovery pathway that is most appropriate for them. It gives voices to individuals with lived experience into decision-making bodies, including the SURG and subcommittees like this, as well as gives value to the lived experience as we design and implement programs, recognizing that often it is including their presence and direction that will lead to the best outcomes in developing systems and services that support individuals in recovery. And that recovery does not begin and end after treatment, but it actually extends all the way through the entire continuum from harm reduction through sustained recovery. So a couple of recommended subject matter experts would include speaking to recovery communities, including Foundation for Recovery. They are our statewide recovery community, but certainly we have others. Dr. Kelly from Harvard University, who really has specialized in identifying the multiple pathways to recovery. And then certainly inviting individuals with lived experience to this committee as you are developing some of your recommendations. So recovery-oriented systems of care and support. These include peer recovery support services certification. So now individuals who wish to become a peer can receive individual level certification. We've also provided some support for programming for recovery-oriented faith-based organizations, recognizing that for some individuals, a strong connection with their faith community is one that is of greatest value to them. So helping those communities be more accepting for individuals who are struggling with addiction or engaged in recovery. Establishing alternative peer groups, supporting recovery high schools. Recovery Friendly Workplace Initiative is another one where we're partnering with businesses to support their evolution and being able to employ and help people remain employed when they're engaged in recovery. Supporting the development of recovery communities statewide. Examples of those include Foundation for Recovery, NAMI, There Is No Hero in Heroin, in Nevada's Collegiate Recovery and Prevention Community, NRAP, there at UNR. And then I just wanted to put a special call out in here that for a very long time, recovery was really considered an add-on to our formal treatment delivery system. In the way that Nevada is conceptualizing recovery services is not that. We are really looking to identify distinct funding for community-based recovery supports so that we can empower recovery services to develop outside of formal treatment services. Certainly there are touch points to them, but the recovery community and those recovery services are separate and distinct from formal treatment services. And with that, Madam Chair, I will hand it over to you to see if there are any questions or conversations with the committee.
Thank you so much, Dr. Woodard. Are there any questions from our subcommittee members? I had one, Dr. Woodard. When you had mentioned the, I wanted to know whether or not the provider service search is interactive, meaning, can family members, go onto this website and perhaps see where they would want their family member to be at?
Yes, this is available and online for the public. Anyone can use it. What it does not currently do, which we are hoping for that crisis care hub, as I had mentioned before, it doesn't give you an overview of where care is available. It just gives you the information necessary to determine who is in the geographic area that you are seeking, what levels of care they provide, and if they treat adults or adolescents or both. And as I mentioned, it does give some information as it relates to quality and some of the quality indicators that we have identified. But it would require someone to actually reach out to those providers to determine if they are currently accepting new patients.
All right, thank you. Any additional questions for Dr. Woodard? No? Okay, then we will go on to agenda item number 6, which is for us to consider recommendations for presentations from subject matter experts or did I skip something?
No, Madam Chair, please proceed, and then I will add in information for the work group.
All right, thank you. Okay, and this will be from Dr. Terry Kearns. Dr. Kearns?
So, Madam Chair, prior to or before Dr. Kearns goes, I just wanted to note for the work group that there are a number of recommendations that are currently in the spreadsheet, which is populated and has been posted on the Attorney General's site. This relates to homework that the work group was assigned at the last SURG meeting, which was to review the Interim Health Committee's recommendations. So I just wanted to note that much of what Dr. Woodard shared has come in the form of recommendations that are included in that spreadsheet now. So things like medication-assisted treatment, talking about the hub and spoke model. So I won't belabor this, but I just wanted to note that those recommendations from the February and the March Interim Health Committee meetings are included in the spreadsheet that that is posted on the Attorney General's site for work group members to look at prior to our May meeting.
Great, thank you, Kelly. Okay, and now we can go to item number 6, which will be presented by Dr. Kearns.
Thank you, Madam Chair. What I wanted to say is that Dr. Woodard went over a very comprehensive but higher level list, and then also considering those recommendations that came out either as gaps in programs or recommendations for additional programs that was presented in. There were 2 joint interim standing committees to HHS going through those and looking at specific people we may want to bring in to discuss more in detail what they recommended or where they found gaps. And what I would suggest is, and looking at that tracker as recommendations are put on there, is there a specific item from either what Dr. Woodard talked about or also from the testimony to the Joint Interim Standing Committee to HHS that we could pull in that could provide us more in-depth information. And when we're thinking about that, as has been mentioned already, we do have members of this committee, of the larger SURG, of the Advisory Committee for Resilient Nevada. We have the capability to reach out within our state for experts. Other states, if you know of programs or policies or anything that have been implemented that are working well that we would like to hear more about, and also those national experts. So we do have a list within the Attorney General's office of people who have served or have been willing to serve on our substance use committees that are available. We have the list of the Advisory Committee for Resilient Nevada. We have the list of all the presenters from the testimony. which we can provide all of those to you. But if you have recommendations as well on things that you would like to see for future meetings, or that you would like to present on as a subject matter expert yourself, we welcome that you push those forward to myself and to the SEI, and we can facilitate getting those members subject matter experts to present.
Great. So,
Madam Chair, I see that Lisa Lee has her hand raised.
all right, Chair recognize Ms. Lee.
Thank you, Madam Chair. I have a recommendation. So one of the presentations that myself and several other folks were part of was a presentation on overdose prevention sites. And this was a piece of legislation in our state last session that kind of morphed into legalizing drug checking supplies, including fentanyl test strips, but it began as an overdose prevention site bill. I'm wondering if we could have Caitlin C. from New York. She's from the Washington Corner Project, which is the first overdose prevention site in the United States. And that opened in January. So I'm thinking by this point, they probably have a pretty good idea of how that's going and the data that supports that. I'm wondering if we could be in contact with her to present on that. Thank you.
Thank you.
That's a great suggestion. I'm sorry, Madam Chair. I was just going to say, I've heard that presentation. I think that would bring depth of information to the committee.
Thank you. Any other? Kelly, do you see any? I'm thinking that Dr. Dixon.
Yeah. I had already proposed that I would give a talk on what medication-assisted treatment is these days. But also, besides that, a couple of things. One is the bridge program that we're working on. We're having a webinar tomorrow, but the bridge program is to try to get emergency rooms, doctors and staff to refer people into treatment. They're not very good at that. They tend not to do very much of it. So we're trying to get a pilot program going with several of the hospitals here in Clark County. And so I think maybe folks might want to hear more about that. And then this is just a piece of information more than well, I could do a presentation on Kratom, but we talked about Kratom briefly at our last regular meeting and trying to get it put on the schedule to be a Schedule 1 drug. And the Board of Pharmacy was all set to do a regulation and have a hearing on that 2 weeks ago. And it was postponed. Actually, it was canceled. And so we have since communicated with the head of the Board of Pharmacy. And it looks like we might do better to try to push legislation through rather than do it as a regulation. So we might want to talk about that some more and maybe being one of the groups that supports it, because there's going to be pushback from the industry.
All right, thank you, Dr. Dixon. Any other? Any other members with questions and or comments? All right, Kelly. Do you see anyone else that I can't see?
I do not, Madam Chair.
All right, thank you. All right, so we'll go to agenda number 7. Our May meeting date will be the next meeting, May 16th at 8:30 a.m. So hopefully everyone will put that one in their on their calendar so that we can proceed. All right, our next agenda item is item number 8, public comment. So again, public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020.
Madam Chair, I don't see any hands raised for public comment.
Any telephone?
If you're on the telephone and you would like to unmute yourself to make public comment, please do so now. I don't hear anyone, Madam Chair.
All right. So it looks like now we'll go to agenda number 9, and that's our adjournment. And I just want to say that this has been very productive, and I really want to express my pleasure and my understanding that Dr. Woodard and Dr. Kearns, I do appreciate everything that you have covered, and we will be calling on you, as you know, on a regular basis. So, and I want to thank Kelly, my wingman, for helping out with this subcommittee information. And thank you all for being on. And if no other items, we will close the subcommittee session at this time. Thank you so much for everyone.